Welcome back, team. We're going to talk about incisional nail procedures this time, or at least one of the soft tissue procedures. So regular viewers will have seen me use this slide before or some version of it. When I'm thinking about nail surgery, 90% of the time the phenol technique is going to be your go-to technique. It's fabulous, sometimes augmented with some soft tissue work, but you can look at doing incisional techniques, and I'd like to classify them really into four main ways. You can look at just doing soft tissue procedures. You could do partial nail incisional techniques. The classic, of course, would be the Winograd, but there are others. You could do total incisional nail techniques. The classic would be Zadig, but of course there are others. And there are even amputational options. We would use those very rarely, but occasionally for a fifth toe, particularly taking away the tip of the toe, a terminal cyme is a good option. Back in the day, around the Second World War, it was relatively common to see the distal half of the distal phalanx removed. That's a lapidus procedure done for really bad ingrown toenails, but it's thankfully rarely performed now. I think I've done 2 for awful ingrown toenails, so certainly not our go-to. But many years ago, when I was still seeing some of the old boys from the Second World War, we'd see guys with missing half of the distal half of the distal phalanx. Anyway, we're going to talk about incisional techniques, soft tissue, and the Howard Dubois procedure. So you'll get some cases where you've got some pulping at the distal aspect of the toe. Picture on the left from Dr. Ian Crawford's book, which is absolutely your go-to for soft tissue plastic work of the foot. So what's that? Lower extremity soft tissue and cutaneous plastic surgery, 2nd edition. Used with permission. Thank you, Mary. Thank you, Doc. On the right is from Hetherington's book, which you can find online now, nicely held to by Kent State Uni. That was Vince Hetherington's book from, do you know what, looks for the reference. It would be the late 80s. I'm going to say 89, something there or thereabouts. Quite an old book, a little bit dated in some of the paragraphs, but still very useful, and it's nice and free online. It was my go-to reference when I was learning to be a jobbing pod surgeon, because I couldn't afford McGlamorys. So I have a soft spot, excuse me, for that book. And chapter 33 by Lako, I still quote that a lot. It's quite a good old paper, really. As I say, a bit dated, but useful. So he would talk about shoveling of the distal aspect. So if you've got a nail that's been removed, been shed, you'll sometimes get that distal embedding ingrown toenail. Fairly recently, I heard this referred to as the beluga toe, and I really like that idea of kind of from the beluga whale, that distal pulp of a toe. Now, we're taught in the UK ingrown toenails are caused by the nails growing into the skin. Okay, that's fair enough. However, sometimes it's not the skin's fault. Correction. Sometimes it's not the nail's fault. Sorry, it's the third time I've tried to record this video and people keep walking into the front room. Sometimes it's not the nail's fault. Sometimes it's the skin's fault. Sometimes the skin's in the way. In this instance, the nail grows into the skin. But the nail comes across as a bad guy, but it's not his fault. And so there are a range of soft tissue incisional procedures. You've perhaps heard me talk about these before, and this is the one for that distal ingrown toenail. So the Howard Dubois procedure comes from 2 papers. Howard all the way back in 1893, and Dubois from 1974. And they wrote up exactly the same technique. 50-some years ago, when Dubois did it, the internet wasn't quite the monstrosity we have now. And so he probably was not aware of Howard's original technique from, well, what's that now, 130 years ago. But they're the same technique. So it's called the Howard Dubois. And there's a reference there, bottom right, from the Indian Journal of Dermatology. It's actually not written about often enough, this technique. And there are other incisional techniques you'll hear me talk about in other videos, such as Van den Bosch, such as the Noel, Rosa, Super, etc. And there's, going back to Dockery's work, so there's the schematic of what is done. And effectively, it's an ellipse or sometimes a crescentic cut, taking away some skin from the distal aspects of the toe. And it allows you to pull down that dorsal distal aspect of the toe. Let's make a little mouse. What colour should we go? Let's go for green. So it's basically taking out this section of skin here and then taking the nail tuft down, or at least taking away that skin so the nail can grow forward and not grow into that tuft of skin. Sometimes I refer to this as the Mikado fish mouth incision. Mikado is one of those old, I think he's been dead about 10 years, one of those old formative American podiatric surgeons who produced this excellent series of 30 VHS videos, back in the day. And these were the other, this as well as Hetherington were the two sources I learnt most of my pod surgery from. So I have a real soft spot for Mikado, and you'll still find his videos online called The Art of Surgery. Again, somewhat dated. I remember him fixing a lapidus arthrodesis with a single K-wire. That would not be the standard of care now, however, back in the day. So you can either do a straight ellipse, or you can see from this paper from Ha and Kim, it's more of a sort of a crescentic type cut. So here's a case that I did about 6 months ago. This young guy works as a bartender, so he's on his feet for many hours every evening, and he had this. Let's pick a different colour. What should we go for? Let's go for blue. It's going to stand out. You can see that he's got quite a lot of pulping at the end of both his toes. And we did actually a bilateral case for him. All this is extra tissue. The nails started to engross. It was a case of constantly keeping those nails short. So we marked him up, and then all of this tissue goes. Now, this would be done in the office, as the Americans would say, or in clinic, if it was a skin-only procedure. Hold that thought, I'll come back to it in the last few slides. So a little video coming up, done as part of my work that I do with Zespodiatry in Oxford. So Lottie's on the camera. There's a little bit of camera wobble because she was watching me and not watching the video. So at some point in a few seconds you'll hear Lottie and I chatting away in the background. But you can see now I've done the skin work. There was a video of me doing the skin work. It got lost in the ether. Apologies for that. But you can see we've taken away an ellipse of skin, and effectively now I'm pulling down that dorsal distal skin to allow for that nail to grow forward. So in a few seconds you might hear some chatting in the background. There you go. That's Lottie and I chatting away. Crappy suturing. Don't look too closely at the suturing. It's not my finest work. I'm trying to do some
I'm not doing a master. I just
low-grade teaching. That's Lottie sounding all posh like she does. Private school education, worth every penny. Right, I'm going to move swiftly on, but you get the idea. So you can see it's quite an unhappy wound. So he was on antibiotics, and he was back to work a little bit early. However, 2 months down the track, it healed quite well. So you can actually see it actually had quite a Bowes line, B-E-A-U, Bowes line, so some cessation of nail growth. And then change colour. Let's go for red. You can see all this traumatised nail, that's all going to grow forward and shed. So at 2 months he's all healed and he's looking quite happy. And then this is him about 6 months, and you can just see you've got a little fine scar, but that nail is now going to grow forward. And from some of the papers where they've done some longitudinal studies, they've shown patients at 6, 12, 18 months out, and the nail really grows quite back very nicely in lots of these cases. So it's one of these underused techniques. Here's a little video that I've purloined off Instagram. Excuse me, so apologies to the original author. I haven't got a link for you, but it's a little Instagrammable, TikTok-y whiz through. So he's taken a 10 blade. I like a 10 blade for skin. Taking away that ellipse at the tip of the toe, down to bone, taking away all soft tissue, super quick suturing, and closed. How quick was that? Yeah, that's a nice little TikTok-gram. But you're getting the idea. And then just, I said hold that thought in terms of sometimes done with bone. And certainly this was from Mercado's original work, where he would use this as really an approach for a subungual exostosis. So this was a case, you can see I'm in theatre for this one. I've got a couple of my colleagues in the background. And we've taken an ellipse at the end of the toe. But what it really allowed me to do was to dissect the skin away from the bone. I think you can pretty much see that you've got quite a kind of a sharp point of bone. It's not really good colour. Let's see if I can change it to, let's try blue. You've really got quite a sharp piece of bone at the end. So that needed ronduring back. And it was the bone problem. So Got quite a low index of suspicion for doing an x-ray on these, and bottom line is if I need to do bone, I take them to theatre and want to do bony work in a clean environment. If it's just skin only, I'm quite happy to do that in the clinic or in the office, as our American brethren would say. And this was this particular case. Move the mouse. This was our particular case. Heart closure. They're supposed to look like a Cornish pasty. That's a question I get from patients all the time. In fact, if I had £1 for every time I'd been asked if that wound looks right, I could have retired years ago. They're supposed to look like that, and of course they flatten off with time. So there we go, guys. The Howard Dubois procedure, useful little adjunct for that distal embedding ingrown toenail, something to add to your armamentarium. Consider x-rays if you think there's some bony involvement, and obviously have some suture skills.